Coming to you from the American College of Emergency Physicians annual meeting in Boston, Massachusetts. This is ReachMD, and I'm Dr. Matt Birnholz. I'm joined by Dr. Clifton W. Callaway. He's from Pittsburg, Pennsylvania. He received ACEP's Outstanding Contribution in Research Award for his more than 2 decades of research into brain resuscitation after cardiac arrest. He's professor of emergency medicine and vice chair at the University of Pittsburgh Department of Emergency Medicine, where he holds the Ronald D. Stewart Chair in Emergency Medicine Research. Dr. Callaway, welcome to you.
Great. Thanks for having me.
So, before we get started talking a little bit about the background through which you earned this award, tell me a little bit about how you came into emergency medicine, how you came to ACEP, which I suppose is self-explanatory in coming into emergency medicine, but I don't want to presuppose.
Right. So I actually became interested in emergency medicine when I was an undergraduate. And at that time, I was very fascinated by research, and I had thought I'll probably go to graduate school after undergraduate and had sort of predilection that way towards research. But one of my college roommates actually said, let's take a first aid class. Couldn't find a first aid class, so we took an EMT class. And at the end of that, we had license to be EMTs, and he said, well, let's get a job. So we got a job on an ambulance, and this was kind of a lark for me, but we became involved with EMS and started working, and pretty soon we're working full-time and doing classes during the week and, riding the ambulance all weekend, and it was just addictive. And that was really what I wanted to do from that point on. So it was EMS that brought me into actually even going to medical school and flirted with all the different specialties in medical school, but, always came back to emergency medicine.
Almost seems like a joint friendly competition in a way, spurring each other forward to continue on the EMS. Did he also go into?
Yep, he is also an emergency physician and is medical director of a hospital here on Cape Cod.
I love that story.
Yeah.
Why don't we turn then into your research career? How did you get exposed into the research arm of emergency medicine?
I had actually I had been interested in doing research, and I was fortunate enough to do an MD PhD program through my medical school. And my research at that time was in neuroscience, so I was very fascinated with how the brain worked and pharmacology of the brain and things that made the brain either work well or not work well. And so sort of levels of consciousness were the thing that I thought was fascinating. When I went and was training in emergency medicine subsequently, the obvious application of that was that some people are in a coma. And so coma is, a disruption of consciousness, the very thing I had done my graduate work studying. And how to treat it, I asked my teachers and mentors, well, this woman's in a coma, what are we doing? And they're like, I don't know, this is not, we don't have a treatment for that. And I found that just totally unacceptable, that, there was a person whose obvious biggest problem was coma, and in that case, coma after cardiac arrest, and that there wasn't anything that experienced people knew to do. And, that's really the nidus of research. When you have a clinical situation where you are dissatisfied with the therapies you have and what you can offer the patient, that's when you're motivated to do research. Let me fix that.
Right. And I imagine that must have been a huge part of your ultimately becoming a very instrumental agent in both national and international resuscitation guidelines that are pushed out. You apparently are central to that.
I am a member of a very large team and a very large network of people who are equally passionate about making sure that every patient gets the best care and that we really move the needle so that we prevent untimely or premature death and disability. And that's in our example, in our case, we're studying resuscitation and cardiac resuscitation. But that's the general theme, I think, of emergency medicine is, we want to prevent threats to life and limb and things that could be prevented, could be fixed, could be improved if we act in a timely manner.
Has it come a long way since you started working on it?
Very much. So in the past 2 decades, when we began to talk about cardiac arrest and resuscitation, we would always start with this slide, which was a very depressing slide. Survival after cardiac arrest hasn't changed in 30 years, and that was true right up to the 1990s. But now that same slide, we all changed, and it says cardiac arrest survival has steadily increased for the past 15 years. And that's true in this country and every country that's kept statistics over that period of time. And there's no silver bullet. It's not been through any single intervention, but it's been through the development of systems of care, applying things that we knew worked, making sure that every patient gets them in a reliable manner, and then putting all the pieces together in a concerted plan of action that's steadily increasing survival. And that's just tremendous to see that.
Have Good Samaritan Acts also increased along that time span, or would you attribute most of the increases in survival to what happens once they get into a hospital in that golden window, say?
No, the biggest intervention to improve survival, the strongest lever, is actually bystanders. Folks activating the emergency system and then making sure that they do something for the patient immediately. We need to have that whole system of care. But the first couple of links in sort of the chain of survival that we always promulgate in the American Heart Association's chain of survival, the first 2 or 3 links are all done by citizens who are not professional responders. They recognize the cardiac arrest, they call 911. Now they can pull a defibrillator off the wall and actually apply the initial therapy. We're empowering people to do CPR even if they're only hearing about how to do it from the 911 operator, all of which is protected under Good Samaritan laws, state by state. They can only help the person, and those things I really think are what's driving the increase. From the hospital, we're receiving people in much better condition, and then it becomes easier for us to gild the lily and actually get the folks who are on the fence and get them out of organ failure, get them out of coma, and do some of the tricks we have. But, boy, you can really drop the ball if that first part of the system was never activated or was activated too late.
Right. Well, why don't we turn to coma again, since you taught it was such a big part of what drew you into the field and into research. Clearly, we've come a long way. Anybody who's been practicing can say we have made progress in that area, caring for people in that spectrum, but there's a lot more to do. Where are we now?
The problem of the patient with brain injury is that there's no, I tell families, there's no salve, there's no pill, there's nothing I have that like sort of grows brain for you. We do a great deal of our work to try to prevent secondary injury. So we manage the blood pressure, we manage the ventilator, we manage temperature in ways that make the environment better for brain recovery. But it's still a situation where we don't have a cure or a support system or something that can regenerate the brain or support the brain or cure the brain problem. And that's where a lot of our research is focused. What are the molecular events? Are there particular things happening that actually a drug or a therapy might reduce that damage? More and more we recognize we made assumptions about what was happening in the brain after an injury, and that those assumptions were too simplistic, that there's a lot more physiology going on, a lot more, many more molecular events. Some of those may be amenable to treatment, and I don't know which one of the ones will blossom into something we bring to the bedside, but it's very important that we keep looking under every stone.
Interesting. I mean, not to put you on the hot seat, but any examples of some of these assumptions which just did not bear out over time, that sort of took you aback as you were monitoring over this sequence of time of researching, where you said, I always had that as a base assumption too, and it just doesn't seem to bear out. Yeah.
Simple example would be brain swelling. We would meet people who've, say, had a cardiac arrest or had some event, and they have cerebral edema early on. We look at the CAT scan, we can see the brain is all swollen. It seemed obvious. There's lots of dead cells. This is, the brain is swelling because all the water is rushing into these dead cells. So we peel that back. It actually is probably more like a hypertensive urgency. Where some of that edema is vasogenic, and it's because the capillaries have all been leaky for the past hour or two, and a whole bunch of fluids going into the brain. And by God, yes, if we just leave that alone, the person's brain will in fact die. And it will, in fact, have its circulation cut off, and the person will progress to a terrible state. But now that I know that it's maybe not just dead cells, that there's still viable cells there, and that they're suffering from brain edema, I have to look upstream and say, well, how could I have made that edema not happen in the first place? And, if I catch it early enough, can I actually, do some therapy to suck the water back out and make those still viable cells not die? How big of a problem is it? In our series, 20% of patients have some cerebral edema when they hit the hospital after cardiac arrest. So it's not every patient, but it's a lot of patients. And in the past, we thought, oh, that's just a bad sign. That's a sign of horses out of the barn, game's over, we should, lay crepe. Not so. This is an opportunity where you look at the physiology and say, that's actually maybe something that there might have been a treatment I could have started in the ambulance so that this was not happening at all.
Fascinating.
Yeah.
Well, if you're just joining us, this is ReachMD. I'm Dr. Matt Birnholz, and we're at ACEP's annual meeting in Boston, Massachusetts. I'm with Dr. Clifton Callaway, and we're talking about everything to do with resuscitation brain research. Continuing on from there, actually, you gave me a great segue. You talked about upstream. You talked about catching things early. Mm-hmm. I understand that you and your research team were strong proponents of trying to look into hypothermia as a potential preventative treatment for brain protection in that sense. Tell me a little bit about that story, that mm-hmm. narrative that you guys and your team pushed these understandings through.
Right. Hypothermia had been a treatment that people have considered for all types of brain injury for over 50 years. So it was well known that if somebody fell in the water, maybe were submerged for some length of time, you brought them back out and restored circulation, that they would tolerate it tremendously better than someone who was at normal temperature. And by extension, people tried to lower the temperature after injuries. And in the laboratory, where everything's nicely controlled, it works every time. It's a intervention that's always the positive control in animal studies. You use that as the intervention to show that you can detect a beneficial effect when you compare it to an experimental drug. And we, myself included, did many laboratory studies where we tried different temperatures, and we found that lower temperatures for the first day or so of coma made a variety of animals recover better. And it was a small step to take that to clinical trials. Our colleagues in Australia and in Europe did those clinical trials in the early 2000s and saw benefit compared to prior treatment where folks were allowed to have whatever temperature. And many places adopted hypothermia as a therapy for coma. Recently, other colleagues in Scandinavia, Nicholas Nielsen, they've compared different temperatures, and when they controlled folks with a temperature of 33 degrees or 36 degrees, they saw no difference in those two groups. Everybody had temperature controlled, but it seemed like the absolute temperature was not the critical factor.
What do you make of that?
Yeah, I'm encouraged because their groups both have survival that is dramatically better than back in the control groups we had in the early 2000s. So a decade later, both of their intervention groups have the 50-55% survival that the experimental groups had in the 2002 trials. So, I think it's true. I think that the precise temperature didn't matter, but, in a critical care milieu where temperature is part of the whole package that's addressed and patients are controlled at one of those temperatures, they do better. Our current recommendations say, you should control temperature, because the old way that we did prior to 2000, that didn't work so good. Now, it works much better if you control temperature, but it looks like it doesn't really matter if you pick 36 degrees or 33 degrees, pick one or the other. If you're studying other types of diseases, traumatic brain injury, stroke, and so forth, you know that temperature affects some physiological processes that we think might be important. I mentioned brain swelling earlier, cerebral edema. If you lower the temperature, the brain swelling goes down. If you raise the temperature, brain swelling goes up. So if I have a patient and I've seen some signs of cerebral edema, I tend to pick a lower temperature rather than a higher temperature. If the person's having seizures, again, they're worse with high temperatures, better with lower temperatures. I might pick a lower temperature. But let's
flip that around, though. What about the other case? Is there any? What are the situations in which a higher temperature is advantageous?
Oh, if you're bleeding. So if the person's got a bleeding risk, or you maybe you're fresh post-operative, or GI bleeding was a part of the clinical picture, then a higher temperature makes more sense, because lower temperatures are going to make that worse. There's some debate about, well, what about sepsis? So if the person's ragingly infected, white blood cells may not work as well at a lower temperature. So that might be a piece of clinical information where you might choose a higher temperature rather than a lower temperature. What I won't do is just let that person go without any control at all, and I won't allow them to have a fever. The picking of which temperature might be better for which subgroup, well, that's the cutting edge. That's where research needs to be done now. So hopefully someone out there is, plotting the clinical trial in septic people, the clinical trial in seizing people, to find the optimal management strategy.
Right. It's what comes to mind when you talked about that, the study that did not find a real survival difference between temperature control. So I take it wasn't stratified at that time for necessarily the reasons by which the control was trying to be achieved?
Yes. So in the most recent trial of 33 degrees versus 36 degrees, they did not stratify. So it was patients who were included were randomly assigned to either temperature. They've done a wonderful job of looking at both a priori subgroups and post hoc subgroups, trying to see if there's any signal that the people who had one feature or another feature might have had a differential benefit from one temperature versus another. They did not detect any, but all of that is statistical analysis separate from the primary hypothesis. And with 900 patients, you can only cut the data so many different ways.
That's true.
So I should come up with a new hypothesis for you if I say, try this temperature management strategy versus another one. Though I think we all practice. We all practice with what we think from physiology many times way beyond what we have randomized trials to tell us to do.
True. And I'll be all ears for your next hypothesis, of course. Well, before we wrap up, I want to just touch base on the post-cardiac arrest clinical service that you've helped coordinate with the team that, from what I hear, cares for hundreds of patients. Tell me a little bit about that service.
Yeah, this has been a great collegial effort among many specialties at my institution, and it really is one of the blessings of where I've worked is that we have not had silos of or turf areas between specialties, but we've actually been able to look at the patient's experience and create a service line that takes care of people across multiple specialties. My partners in this service and I, we're talking about all this research and helping to write guidelines and saying, we should take care of patients a certain way. And really, at one of those meetings, we said, well, if we can't make sure that this reliably happens to the patients in our own shop, we've got no business telling, other people that, they should follow this guideline or that guideline. So we started a QI program. We followed patients. We would meet patients when they arrived at the emergency department when my partner was taking care of them. We'd go up to the ICU and we'd talk to the cardiologist and we'd talk to the intensivist and we would, kibitz. They all looked at us and said, well, if you're going to kibitz, you better write a note and take responsibility for this, and, dubbed us a consult service. And we just started following the patients. Initially, it was tens of patients per year. I'm at a academic medical center, so we had some referrals. But once we established that service line, many hospitals started referring patients in, and patients are now transferred specifically for that service line. And again, not for any one of us as a specialist or a physician, but for the whole service line that involves the emergency medicine component, the interventional cardiology component, the cardiac ICU component, the neurological component, the rehab component, all of the pieces that are necessary to get a person through a severe injury with multiple organs affected. This last year we have about 250 patients who've come to our institution for this particular service line. and survival has increased, and their long-term survival has increased as a consequence, which is really, really gratifying.
It is, and it's a wonderful way to cap off our conversation today. I am going to take as a life lesson your quote that if you're going to kibitz, you better write a note,
Right.
which is a wonderful, wonderful life lesson indeed. I've been joined by Dr. Clifton Callaway from the University of Pittsburgh. We've been talking all about his work, his research, and the award that he won through ACEP. Again, this is ReachMD, and I'm Dr. Matt Birnholz. And Dr. Callaway, thanks again for joining us.
Thank you. Thanks for being interested.
For access to this and other podcasts, come on down to reachmd.com, and thanks as always for joining us.